the state where your body tries to stay the same, tries to maintain a status, right? So basically with the heartbeat doesn't want to get too high, doesn't want to get too low, wants to stay the same. Blood pressure, same thing, right? Doesn't want to get too high, doesn't want to get too low. Body temperature, respiratory rate, electrolyte balance, right? All of these, you don't want too high, you don't want too low. You want it to be nice and steady, right? That Goldilocks zone, that just right. Okay, so the body needs to be able to maintain homeostasis. This body wants to maintain a steady value for all of these mechanisms. So, because of that, we can use these mechanisms to kind of gauge the status of the body, right? These are our vital signs. For example, we can look at the temperature of the body to see if the body is normal or see if there's something abnormal going on. Perhaps the body has a fever, or perhaps there's hypothermia instead. We can use temperature to check that. Right? Respiration, same thing. We have certain breaths per minute that we expect. Too high, we have, actually, does anyone remember what the word is for too high of a respiratory rate? Tachypnea. Tachy meaning?
Fast.
What is that?
Fast.
Fast, good. And then the apnea being breathing, right? Make sure you know your medical terminology as well, right? Make sure you know these roots, because they will help you figure out these words if you're not quite sure. Right? Apnea especially very fun one, because you have tachypnea, right? But you may have heard of something like sleep apnea, right? Using that same apnea ending, right? What is apnea?
Unable to breathe.
Unable to breathe, right? Lack of breathing, a meaning without. Right? So knowing your word roots will be able to help you there.
I just want to emphasize real quick, guys, like this slide right here, these vital signs, big start on that. Commit that to memory, because they will ask you questions still on your CT-MR registry about vital signs. You know, like, oh, it's patient here, it's easy. These are the points right there you can't afford to throw away. And they'll give you situational questions about the vital signs being too high or too low, so you can know what that normal range is by memory, or learn how to write that out on your scratch sheet before you take your test.
Yes, Kamari.
When you say child, do they have a specific age range as far as toddler or infant?
That's a good question. Do you remember, Mr. Donahue,
Say again?
for a child, is that up to 6 years, or do you remember the exact?
6 years.
6 years.
6 years up, I'm sorry. 6 years and below would be like infant, babies.
Okay.
Because last time we got a question for infants.
Yeah.
Grade two.
Okay. Okay, so these are the respiratory rates for adult and child. You have pulse, also separated into adult and child. Blood pressure, systolic, diastolic. Systolic being when the heart contracts, diastolic being when the heart relaxes. Okay. Let's see. All right. So as far as body temperature goes, normal body temperature is 98.6 Fahrenheit, which is 37 degrees Celsius. The hypothalamus plays a role in thermoregulation. Hypothalamus. So we talked about the hypothalamus last semester, right? Where is that hypothalamus located? It's so it is anterior to that midbrain. Okay, you can see it right here, right? So here's our brainstem, right? What is this round thing? Remember? Pons. Okay, this thing here. Right, so we've got our midbrain, and then there's our hypothalamus. Okay. Has anyone watched that old movie Osmosis Jones? Yeah. Yes. Okay, I see some nods. Do you remember, I think it was like in the second half, right? The body was starting to get a fever because the bad guy was attacking a certain part of the body. What was the bad guy after? The hypothalamus, yes. The bad guy was going after the hypothalamus. Go back and watch it again, right? You can say that is for class, right? It's educational.
Mr. Fung, I think you aged us better.
Okay, I mean, I guess I watched it in school in 8th grade, so that was a while ago. Okay, it's okay. It's a classic. Go back and watch it. Okay. So how do you measure body temperature? We do have several methods. Oral is the one I think we're most familiar with. So with oral measurements, we can expect a range. Okay, right? 98.6 is that midline, but it can range from 97.7 up to 99.5. That is considered our normal range. Above that, then we would consider that as febrile, right? That would be a fever. Okay. We have tympanic. So where would we be measuring if we're checking the temperature using the tympanic route? So this would be temporal. Actually, hold on. Right, so this here, right, if you're measuring the forehead, right, this would be the TA. But what about tympanic? Think about your anatomy. Where have you heard the word tympanic before?
Eardrum.
Eardrum, that's right. So the tympanic route of measurement is checking the temperature through the ear. Okay. Axillary. If you're measuring the temperature through the axillary route, how are we measuring temperature? That's right, armpit, right? Axillary. Okay. Temporal artery. We said that it's going to be here at the forehead, kind of like in this picture right there. Rectal. How would you measure the temperature rectally? That's right, putting it up the rectum. Okay, so oral temperature, right? Usually thermometer goes under the tongue. Leave it there anywhere between 20 seconds to 3 minutes. And we're expecting that 99.7 up to 99.5 Fahrenheit range.
So now I have a question for you guys on these 5 routes here. Of those 5, which one is the most accurate?
Rectal. So why don't we just use rectal measurement on all patients? Very invasive, that's right. We don't need it to be that accurate most of the time. Okay, for our tympanic measurement here, we see that we have a slightly larger range, 95.9 degrees to 99.5 degrees. This doesn't take us long, usually just about 3 seconds to do this measurement. Rectal measurements, we're looking at leaving it there usually between 2.5 minutes up to 5 minutes. So one of the important things to note about rectal temperatures is that the measured rectal temperature is about 1 degree higher than the oral temperature. And that makes sense because the rectum is more inside the core of the body, right? The mouth is more towards the extremity. So the temperature in the rectum is going to be higher than the temperature in the mouth. So rectal temperatures are about 1 degree higher than what you would measure orally. Okay. For axillary temperatures, right, under the armpit, leave it there about 5 to 10 minutes. This one, not as accurate. Okay, so this one is not our preferred method for measurement. And then finally, temporal, right? So we've got this thing that you can just sort of sweep across the forehead. This temperature measurement actually is, well, if you take a look here, 1 degree higher than oral. What does that sound like? It sounds like a rectal temperature, right? So the temporal measurement is going to closely mimic the rectal measurement. Okay, those should give you similar numbers. So, what if the temperature falls outside our normal range? If we do have an oral temperature higher than that 99.5, we consider that to be hyperthermia. Hyper meaning what? Above, right? And then thermia, therm, right? So that's heat, temperature. Right? So hyperthermia, the temperature is above normal. Okay? So that's what we call fever. That's what we call febrile. On the other hand, if the temperature is lower than expected, right? So our lower end of the oral temperature was that 95.5 degrees. So if it's lower than that, that is considered hypothermia. Once again, hypo meaning what? Below. Okay. So hypothermia.
They'll give you situational questions on those concepts, guys, just like with X-ray, where they'll have like the whole scenario play out. Patient A comes into the emergency room, presents with a temperature of 100.5. What is the condition they're currently experiencing? Hypothermia would also be the answer to that one. But make sure you know those terms as well as those average numbers for those vital signs. Because again, that's points you don't want to lose on that registry. Seems like common sense, but it's easy to forget those as well.
So why is it dangerous for there to be hyperthermia, for there to be a fever?
That means your body fighting off. And you could a shot or brain cell.
Okay. All right, so you're saying that fever is usually associated with the body trying to fight off disease, right? So the body raises this temperature to try and make the body a less hospitable environment for whatever disease, bacteria is attacking the body. Right. And so this kind of goes back to that idea of homeostasis, right? Because if our temperature does get too high, then our cells aren't able to function normally. Okay? Cells are very sensitive to temperature. Right? So the cells have proteins. When the temperature changes, the proteins change, and then the body's just not able to function normally. Very good. All right. Prolonged hypothermia.
That's all of us the past 2 days.
Yeah, so big concern right now. Okay. If it's too cold, right? Cold can also lead to cellular damage. Okay. Oftentimes if it gets too cold, it can also lead to loss of consciousness. Now, there are some situations where we actually do want to place patients into a state of hypothermia, right? Because as it gets colder, our bodily functions begin to slow down. And when might it be useful to try and slow down bodily functions? During surgery. So during surgery, like during heart surgery, right, we actually try and cool the patient down to reduce how quickly the body is functioning, right, reduce the rate of metabolism, which reduces the heart rate, right, reduces the need for oxygen in the body. Okay, so if you're doing heart surgery and you're working on the heart, then that way the body isn't placing such a high demand as far as blood flow and oxygen goes. So it's a lot easier to use, what is it, like the mechanical, not ventilator, but, you know, I guess the mechanical heart to keep the body working. No, it's just there's that one there's that one machine that like acts as an artificial heart while people are doing like heart surgery on patients. It's fine. Not important. Not important. All right. Okay, sorry. Moving on. Respiratory rate. So, we like to use respiratory rate, right, as one of the vital signs we look at, because it lets us figure out if the patient is breathing enough. Okay, so usually we want to take a look at how many respirations the patient is doing per minute. Right, so we measure our the respiratory rate in breaths per minute. Okay. Respiration is made of inspiration and expiration. Okay, so inspiration, breathing in, expiration, breathing out. So these numbers, inspiration, expiration, these are gonna be how should I say this? Like when I was learning vital signs, right, I was like, all right, these numbers I expect to be higher, these numbers I expect to be lower. Respiration is gonna be on the lower end, right? You don't breathe that often. It's not like you're taking a breath every second. So normally our respirations are 12 to 20 breaths per minute, right? This comes out to be about 1 breath every 3 to 5 seconds. For children, we see respiration rates a little bit higher, 20 to 30 breaths per minute, right? So every 2 to 3 seconds, children take a breath, right? Okay, so here we do have that age distinction, children being under 10 years old. So children, more active, bodies more active, so they take more breaths. Newborns, okay, so for our newborns, our infants, 30 to 60 breaths per minute. Okay, so they take the highest number of breaths per minute. So for me, I just remembered this is going to be more on the lower end of the numbers that we look at today, right? Because, for example, earlier we were looking at temperature, right? Temperature, really high numbers, right? 95 degrees, 97, 98.6, 99.5. Right? All of these temperatures, high numbers. Respiration rates, low numbers, smaller numbers. Okay. So, abnormalities in respiration rate. Okay. Once again, notice that all of them end in apnea, right? So, tachy meaning fast, brady meaning slow, dis meaning difficulty, a meaning without, ortho. Okay, ortho is kind of a weird one. I'm not sure how to explain ortho. So let's talk about these definitions then. So tachy, right? Faster breathing. So in this case, respiratory rates greater than 20, because our range is 12 to 20. Right? Brady. So then respiratory rate lower than 12 per minute. Dyspnea, just patient having difficulty breathing. Okay. Apnea, meaning the patient stops breathing. Okay. Oftentimes, if you have someone that's snoring a lot, right, high chance of also having sleep apnea. Okay. Where the airway, right, it's just not strong enough, it kind of collapses in on itself, and then the patient stops breathing up until the point when the brain jolts them awake and they're like, ugh, right? They take that sudden gasp of breath. And so it kind of ruins their sleep quality because they're forced to constantly kind of like wake up even if they're unconscious or they don't realize it. Okay, so orthopnea. Orthopnea is similar to dyspnea. It's basically dyspnea with an asterisk. So orthopnea is difficulty breathing unless the patient is upright, right? Sitting or standing upright. And if the patient is laying down on their back, if they're supine, difficulty breathing. Sit them back up, they're okay. So that's considered to be orthopnea. All right. So far, so good? Okay. Next up, we have pulse. Okay, so the pulse is just us feeling blood flow, right? It's almost like the heart is creating a bolus every time it contracts, and we can feel it pushing through. Right? The cardiovascular system is a closed loop system of vessels. If it is not a closed loop, then you'd have blood spurting out somewhere, and that would be bad. It starts with the heart, which is our pump, and then that heart pump pushes the blood through our many vessels. do we remember the pathway in which blood flows through this cardiovascular system? Remember that from last semester? Yes? Okay, so imagine that we start at the aorta, right? Blood is coming out of the aorta. From the aorta, where does that blood travel? Or just in general, what kind of vessels does it go to after the aorta?
Arteries.
Travels to arteries, yes. What kind of vessels after the arteries? Arterioles, yes. After the arterioles. What is that?
Capillary.
Capillaries, yes. Capillaries is where the gas exchange takes place. So that's where oxygen goes to the cells, and the cells give their trash, right, their carbon dioxide, back to the blood. From there, where does the blood go? Venules, and then to the veins. Okay, what are the two big veins that go back up to the heart? Superior and inferior vena cava. Okay, those two vena cavas enter what chamber of the heart? Right atrium, good. In order to go from the right atrium to the next chamber, what does the blood need to pass through? Tricuspid, yes. Pass through the 3-valve one first, tricuspid. Which chamber does it enter after the tricuspid? Right ventricle. After the right ventricle, what does that to pass through before the next vessel? The semilunars. Okay, so the pulmonary semilunars. After the blood travels through the pulmonary semilunars, what vessel is it in? Is it pulmonary artery or pulmonary vein? Arteries. When it's in the pulmonary artery, is this blood oxygenated or deoxygenated? Deoxygenated, right? Pulmonary artery is the only time when an artery carries blood without oxygen. After the pulmonary arteries, where do we end up? In the lungs, that's right. So we're in the alveoli. Once again, we have gas exchange. This time, the blood releases the carbon dioxide into the lungs and picks up oxygen. Once the blood is oxygenated, where does it go? Pulmonary veins, going back to the heart. Which chamber do the pulmonary veins enter through? The left atrium this time. In order to go from the left atrium to the next chamber, what does it pass through? The bicuspid. And what is the other name for the bicuspid? The mitral, M-I-T-R-A-L, mitral valve. After it passes through the mitral valve, which chamber is it in? Left ventricle. Left ventricle contracts, systole. Where does the blood need to pass through before it enters the vessel? What does the blood pass through before it enters the vessel? That's right. This time it's another set of semilunars. Right? Anytime the blood exits the heart, it passes through a semilunar valve. But this time it's the aortic semilunars. And then what vessel is it in once it passes the aortic semilunars? Now it's in the aorta. Okay. So don't forget the path of blood through the heart and the body. All right. So if we do want to measure pulse, if we do want to make sure that blood is pumping through the body properly, we have 3 common sites of measurement: radial artery, brachial artery, and carotid artery. Where is the radial artery? That's right, it's in the wrist. Right? Which side of the wrist are we going to be checking? Lateral. Lateral means the outside, right? So this is my lateral, correct? That's right, anatomic position. This is lateral, thumb side. Right? Why is it called the radial artery? Because which bone is on the thumb side? The radius is here, thumb side, right? So radial artery. Okay. Where do we find a brachial artery? That's right, here by the elbow, right? So there's the brachial artery. Where do we find a carotid artery? In the neck, right here. If we want to listen to apical pulses, how would we do that? with a stethoscope, right? Or you just stick your ear right next to it, right? But I mean, actually, that's what they used to do back in the day, right? Back before stethoscopes, doctors would just take their ear and like shove it against someone's chest. Only problem, very difficult to do that with female patients without getting slapped. So that's why they invented the stethoscope. It's a true story. Okay, so of these 3 sites of measurements, which one do we most commonly use for CPR? This one? The carotid? Yes, that's right. Okay, so when you do CPR, right? Run up to the patient, right? Tap them on the shoulder. Hey, you okay? Right? No response. Okay. Clear the area, right? Activate the emergency response system. You remember CPR training, right? And then, right? You also want to be checking pulse, right? Checking breathing at the same time.
Jamie mentioned, don't forget the infants is different.
Don't forget for infants is different, that's true. Yes. Okay, good. So CPR, right, we measure at the carotid artery. Okay. So, when we do measure pulse rate, we are going to measure, so every time we feel a pulse, right, that is 1 heart contraction. Okay, so we're expecting to see 60 to 100 beats per minute. For an adult, we're expecting to see 70 to 120 beats per minute for children. Okay, notice that for all of these numbers, children always have higher numbers compared to adults. Now, oftentimes when we do check for pulse rate, not only do we want to look at the number of pulses, but we'd also like to feel to see how strong the pulse is as well. Okay, so it's not just about the number, but how strong it is when you feel it. Also, want to make sure that the pulse is steady, right? It's going at a kind of like consistent rhythm, not fast and then slow, fast and then slow. So once again, we have these 2 terms, tachy and brady, right? Fast and slow. This time, instead of apnea, we have cardia. Okay, so in this case, cardia looks like cardiac, so dealing with the heart. Tachycardia, faster than our 100 beats per minute for adults. Bradycardia, slower than our 60 beats per minute for adults. Okay, so just make sure you know these numbers. Also know that 70 and 120 for children as well. Okay. All right. What is this thing? Person stapled your finger? Okay, yes, it's a pulse oximeter. What is the purpose of the pulse oximeter? Measure oxygen, that's right. So we're measuring oxygen content of the blood, specifically the hemoglobin oxygen saturation of arterial blood. However, not only does it measure oxygen in the blood, it can also measure the pulse as well. In MRI, we are going to be discussing heart rate and pulse a lot. One way that we can measure pulse is through something like an EKG. But as you know, in MRI, having an EKG, having something with wires, doesn't always work, especially because sometimes we run into that one issue with EKGs in MRI. Does anyone remember what that was? That's right. The hydrodynamic effect. Yes, the magnetohydrodynamic effect. Okay, so with the magnetohydrodynamic effect, it makes our EKG look really weird, really hard to properly measure pulse. So one way we can do it is through a pulse oximeter in MRI. You can also measure pulse using a pulse ox. Okay. So usually it's going to be placed on the finger. For infants, it may be placed on the big toe as well. But really, it can be placed anywhere there is a surface vessel. The whole idea is that you've got this laser. The laser shoots into the surface vessel. The light bounces back, and the amount of light that bounces back is how they determine the oxygen content of the blood. Right? If the light is more absorbed, then there's going to be like less oxygen. If the light is more reflected, then there's more oxygen. Okay. So, how much oxygen should we expect to see in the blood? In a healthy person, we want it to be above 95%. Is it 95 to 100%? If it's lower, then that might be the situation where they'll need to give the patient a nasal cannula or something like that. Now, what can affect the ability to measure the oxygen in the blood with the pulse ox? Well, patient movement. Patient movement can affect all sorts of readings. Loose or misplaced probes, so not placing it properly on the finger. Nail polish or acrylic nails could interfere with how the laser reflects back into the sensor. And then low blood pressure or poor peripheral perfusion. So if there's not enough blood passing through the vessel, then it can't measure the oxygen properly. Okay. Now, in the case of a heart attack, a cardiac arrest, you should check the carotid artery, right? 5 seconds, don't feel pulse, then begin CPR. What are some signs of cardiac arrest? We have palpitations, dizziness, and faintness. Okay, so what happens if you do have a patient experiencing these symptoms? What sort of things do you think you should do?
Call a code.
Call a code, yes. So call a code, right? Get the code blue team, right? In the case of a cardiac arrest. All right. So non-responsive patient, code blue. All right. Next up, we have blood pressure. Okay. In order to measure blood pressure, we have this device right here. What is the name of this device?
Sphygmomanometer.
Okay, Justin has been answering a lot, so let's get someone else to try and pronounce that word.
Sounds like a Muppet thing.
What is that, Leo?
So we can sign you back up into the rad tech.
Go ahead, Leo.
Manometer.
Sphygmanometer? Sphygmanometer. You're close. You're missing a syllable, though. Anthony, how about you?
I had it, and then we were saying words, and I didn't have it. Sphygmomanometer.
That's a bit closer. All right. So it is sphygmomanometer. Right. So sphygmomanometer. Okay. So Leo was close, right? Just forgot the mo part, right? Just went sphygmanometer. Don't forget the mo. You need mo. So sphygmomanometer. Okay, yes. So our sphygmomanometer and then a stethoscope. Right? Okay. So how do you measure? Well, we have the blood pressure cuff. Okay, and then we have the stethoscope. The whole idea here is that we're going to be looking at when the sounds start and stop, right? Because that's going to be when blood is exerting pressure onto the walls of the arteries during cardiac contraction and relaxation, right? Basically systole and diastole. So we have systolic blood pressure, we have diastolic blood pressure. Systolic being the blood pressure when the heart contracts, diastolic being when the heart relaxes. Okay, so beat and then relaxation. So in a normal person, we're going to be looking at 120/80 as our normal blood pressure. Okay. So just because it says 120/80 doesn't mean it has to be exactly 120/80. It is okay for it to be a little bit lower, but not too low, right? So if it gets below 95/60, now that's considered to be hypotension. Okay, this time, right? Hypo, right? Meaning under, right? Hyper meaning over, right? Low and high. So hypotension, below normal. Hypertension, right? 140/90. Okay, make sure you know all 6 of these numbers. Know your normal, know your hypotension, know your hypertension. Hypertension, sometimes referred to as the silent killer. More common in men. Why? Just is. Okay, so why might we have hypotension? This is most commonly associated with a loss of blood. If you don't have enough blood volume, then the pressure in the circulatory system goes down. Okay. Let's see. If you do lose a lot of blood, the patient can even go into shock. What kind of shock would that be called?
Hypovolemic shock.
Hypovolemic shock. Loss of blood volume, so volume is lower than normal. Hypovolemic shock. Okay. All right, hypertension. So this is also bad because it forces the heart to work harder. Okay, and so you work the heart even harder than it does, it eventually wears out. Okay, so just be careful about your blood pressure. Okay, so in order to measure the blood pressure, we have our inflatable rubber cuff, we have our sphygmomanometer, we will usually have a tourniquet looking thing. Let's see. Actually, no, I'm sorry. No, so yeah, we have the inflatable rubber cuff, we have the bulb, and the whole idea is that you inflate the cuff until you don't hear sounds anymore, right? So basically you've cut off blood flow. And then air begins to slowly drain out of the cuff, and you're looking for the moment that the sounds begin. When you hear sounds begin, right, that is going to be your systolic blood pressure. That's when the blood has enough force to push its way through the cuff, right? And then you're hearing sound, you're hearing sounds, you're hearing sounds, and then eventually the sounds disappear. When the sounds disappear, that is going to be your diastolic blood pressure. And at that point, it means that the artery is fully open and there's no more forcing of blood through the vessel anymore. It's flowing smoothly. Okay, so that's how we measure our systolic versus our diastolic. Okay. Right. And so here we have that brachial artery, right? And so that is what we are going to be compressing when we have our blood pressure cuff. There you go, right? Blood pressure cuff compresses the brachial artery. If you don't hear sounds, then that's when you want to start your measurement. So inflate the cuff as much as possible, right? Once you hear that first sound, that's your systolic. Once the sounds go away, that's your diastolic. Okay. So, next up, we're going to talk about oxygen. Right? So, just to answer this question, yes, oxygen is a drug, right? You do need a doctor's order in order to give a patient oxygen, which might sound silly because I've got oxygen in the air right now, right? I don't need a doctor's order for oxygen. But in a medical setting, right, if you're going to give them oxygen through a nasal cannula or something like that, it does require a doctor's order. Okay, oxygen is essential for life processes. It is colorless, tasteless, odorless, and plays a critical role in efficient cellular metabolism. Your cells need oxygen to function. It makes up 21% of atmospheric gas. So yes, the air in this room is not primarily oxygen. Oxygen is only 21% of the gas in this room. What makes up the majority of air? Does anyone know? Just fun fact. Anyone know what gas makes up the majority of the air? Carbon dioxide? No? Methane? No? What gas makes up the majority of the air? Hydrogen? No? Helium? No? What is it then? Nitrogen. The air is primarily nitrogen. Okay. If the air was primarily oxygen, then it would be very flammable. Let's put it that way. Okay, so oxygen supports combustion, right? In order to have fire, you do need oxygen. You take away oxygen, no more fire. Okay. Oh, wait, what's this? FYI, combustion is the reaction in which a substance reacts with oxygen in the air and releases energy in the form of heat and light. For example, gasoline plus oxygen equals fire. All right. That's right. For those of you in X-ray, your X-ray tubes, inside your X-ray tubes is a vacuum. A vacuum is a lack of oxygen, right? It's the absence of oxygen or gases in general. Why is it useful for things like an X-ray tube or things like light bulbs to have a vacuum rather than oxygen? So what is that?
There's something for it to interact with.
Nothing to interact with? Okay.
So there is no atoms to interact with.
No atoms to interact with? Okay. So, while that's true, right? You're shooting your electrons across at the target, you don't want it to bump into anything. Another reason we have a vacuum, another reason we suck out the oxygen is because your filament is going to catch fire if there's oxygen. Because your filament gets really hot and it's going to burn up. You take away the oxygen, no fire, filament stays intact. Right? So that's oxygen for you. And yes, oxygen is a drug. Okay, so why might we need to give a patient oxygen? If they have hypoxemia or tissue hypoxia. Okay, so right, lack of oxygen, right? Low levels of oxygen, hypoxemia and tissue hypoxia. Okay, so if we do give a patient oxygen, the goal is to try and maintain adequate tissue oxygenation while minimizing cardiopulmonary work, right? So we want the heart to be working not that hard while making sure the tissues have enough oxygen. Okay. Here are the differences between hypoxemia versus hypoxia. Hypoxemia refers to the blood. Hypoxia refers to the tissues. Okay. So that's why you see right, hypoxemia, right? We have the correct amount of oxygen, right? Not enough oxygen in the blood. And then tissue hypoxia, right? Hypoxia dealing with the tissues themselves. Okay. Which tissues are most sensitive to hypoxia? So which tissues are most sensitive to a lack of oxygen? Brain, heart, lungs, liver, right, are very important organs. Okay. If we do have hypoxia, it leads to a change in our homeostasis. Our respiration rate increases, right? The depth of our breathing increases, blood pressure increases, heart rate increases. Why? Because the body's trying to get more oxygen to those tissues. If the brain says, I'm not getting enough oxygen, the body says, okay, better get more blood to the brain, right? Blood carries oxygen, get more blood to the brain. So breathe faster, right? Get more oxygen inside. And then higher blood pressure, higher heart rate, pushing more blood to the brain to try and get more oxygen there. Okay? So the body tries to compensate for that hypoxia. Okay? So lungs are working harder to breathe when that happens, right? May feel short of breath because of that. So oxygen therapy, this helps to reduce that cardiopulmonary workload by making sure there's more oxygen in the air when a patient is breathing, right? Increase the ratio of oxygen to the other gases. Okay? And by doing that, then blood pressure, heart rate, respiratory rate hopefully returns back to normal. So, how do we deliver oxygen to patients in a medical setting? Usually, if you are in a hospital setting, you have these fancy wall outlets that connect to oxygen. Right? You turn the little dial, the little ball floats up, right? And that's how you figure out exactly how much oxygen flow you are giving to the patient. Okay? Very important that you do give the correct amount of flow to the patient. Because once again, oxygen is a drug. With drugs, one of the things we need to make sure about is that we give the correct dosage. Right? So if the patient's on 2 liters of oxygen, you don't want to give them 10 liters of oxygen. You want to be using the correct amount of oxygen. Okay, if the patient is being transported, then we have our portable oxygen tanks here. Okay. Oxygen tanks are usually green in color, or they have green somewhere on them at least. Some of them are completely green, some are green, and then they've got like that silver aluminum looking color as well. Okay. Usually, not all the time, but usually if it is fully green, those are our MRI unsafe canisters. The ones that have that extra like silver thing, usually those are the MRI conditional ones, right? But don't just assume, make sure you check the container to see if there is a label on it. If there's no label, don't bring it into the MRI room. Okay. Oxygen container should also have the word oxygen on it. So these do come with a regulator that has a flow meter, shows you how much oxygen you're giving, and a pressure manometer. It's important that you do check your oxygen system before you transport a patient. You don't want to hook a patient up to an empty oxygen canister. And then do make sure that you secure the entire oxygen system during transport. You don't want the container falling off mid-transport. Now, connected to either the wall outlet or this oxygen tank is going to be either a nasal cannula or one of those oxygen masks. Okay? The cannula is that wire thing with the prongs that goes up into the nostrils, right? You hook it behind the ears, right? Tied here in front of the chin, under the chin. Okay? And these are usually for low flow rates. So 1 to 4 liters per minute. Okay, low flow rates. If you have higher flow rates, right, above 4 liters per minute, then oftentimes there's going to be a humidifier. So you may have seen those masks with like that little extra thing, that little weird thing sticking out of it, right? Humidifier. Okay, so humidifiers are added to the oxygen. Okay, because if you have really high flow rates, it can dry up the nose, it can dry up the mucosa, and that becomes uncomfortable. Okay. For PDs, we have tents or these things called oxy hoods instead. Okay. And then we also have, for mechanically aided breathing, we have ventilators. Okay, so if a patient is not able to breathe on their own, or if they're in a medically induced coma, the patient may have a ventilator. And then we have this abbreviation here, ETT. What is an ETT? Endotracheal tube. Okay, so this tube goes down into the trachea, right? Stops about 2 inches above the carina, and it's supposed to deliver oxygen to the patient that is on ventilation. Okay. All right. And that is the end of our PowerPoint. Okay, so as far as the information goes, do make sure you know all of the different numbers, make sure you know all of the different ranges, and also know your vocabulary, right? To help you with the vocabulary, knowing your word roots will be very useful, right? So brush up on that medical terminology if you need to, right? Prefixes, word roots, those are all going to be helpful in memorizing this vocabulary. Okay, everyone should have the PowerPoint as well. I did email it out earlier. And so time right now is 6:20. Let's go ahead